Good evening. I'm here at the Arthritis Broadcast Network in sunny Victoria today at the Canadian Rheumatology Conference for 2020. Mark Harrison is joining me here. Dr. Mark Harrison is an Associate Professor, Pharmaceutical Sciences at UBC, Collaboration for Outcome Resources and Evaluation, and Professorship at Sustainable Health Care. There we go. Did I get it all?
The mouthful, but yes, you got all that right. Yeah.
Welcome.
Thank you very much. Thank you.
One of the things I'd like to ask you is if you just say a bit about yourself. You've been at UBC,
Yeah.
and I believe that you've worked on some projects with Arthritis Research Canada.
Yeah, that's right. I've been at UBC for 5.5 years now, since I came from England. I most of the time find myself working in arthritis and questions that come up around that condition and the management of that condition. I've worked with Arthritis Research Canada. I'm an affiliate scientist with them. I've worked with Joint Health and Arthritis Consumer Health experts. So yeah, all these organisations have really helped sort of shape the questions that I'm answering and supported the work we're doing. So
We've really appreciated all the work you've done. I've been with you on a couple of occasions listening to your lectures and things. So one of the things I wanted to ask you is, how do we measure and evaluate health policy and health? Because I think that our consumers sometimes don't always know. We just think that there's some big office and somebody just grabs a piece of paper out of the garbage cans and writes on it and says, okay, this is our new policy. But as a patient consumer, I know that that's not true.
yeah, well, when we do it, we're interested in trying to understand when things have happened in the past, like what impact they had on people's lives. And because we're generally not involved in the development of the policy and the release of the policy, quite often we're working with the data that's available to us and then trying to recreate from there. Usually, I know you've just spoken with Ross, but trying to understand, using the data we have, what would have happened if that policy or that intervention hadn't been introduced, and then contrasting that with what we see in terms of patient outcomes after it's been introduced. And that's quite tricky, because sometimes ideally we'd like to measure patient experience or patient quality of life or something that comes directly from the patient, but because we're not involved in the rollout of that policy, then we're restricted to looking perhaps with administrative data. So are patients getting to see rheumatologists? Are they adherent to treatment? Does it appear that people are having fewer complications, or questions like that? So things that we can get at with the data that we have. Whereas ideally, if we were involved at the time that the policy rolled out, then perhaps we could embed some of those questions in and be able to sort of answer those questions more directly.
I think there has to be some hard data in order to keep the government to do what we want them to do, though. So this is invaluable. And you told me just beforehand that you're doing a new project on scleroderma.
Yeah, so that's a really exciting project, actually, and it's one that's it's built on some results of a project I've been doing previously with Arthritis Consumer Health and Arthritis Consumer Experts and Joint Health. In that project, we were looking at prevention of rheumatoid arthritis and trying to understand whether treatments that were being studied in trials would actually be taken in practice. And as I was presenting some of the results of that project, I got involved in conversations with patients and rheumatologists about a different area, which was scleroderma, and a new treatment in that area, which was stem cell treatment for people with quite severe cases of scleroderma, so a totally new treatment option for them. But that project really was looking at whether the available evidence so far from clinical trials was really speaking to questions that people had who might be in the position of deciding whether they wanted to do that treatment or not. So we're in quite a nice space there. So what we're trying to do is work with patients and understand what patient preferences are when they're making decisions about whether they would do that type of treatment. And if we can understand that, then we're trying to get in a position where we can perhaps talk to people who are designing interventions or designing trials and try and embed the patient perspective or the patient priorities in the trial at that stage.
That's exciting.
That's really cool.
Really cool. That's very different than working with the new data.
Yeah, we're excited about it because we think if we can help people design interventions that people want and then study them in a way that's informative to people who might be making those decisions, it kind of smooths that route from initial ideas about what might be helping people to sort of impact in practice. And quite often we see projects get lost on that route because we have good ideas up front, or we think we have good ideas up front, but we don't actually talk to people. And so a lot of money is often spent on studying things which don't actually translate into into practice and in turn patient impact. So yeah, we hope we can help sort of improve
that would be amazing, because that's really a very small group in a way of the arthritis family.
Yeah.
And what you're saying would be very helpful to them. They haven't had a lot of treatment options in a way that have been. That I don't think they've had a lot of people that have asked their opinions, actually.
No, and it's been a great project. We've had a lot of fun working with that group of people. They're very engaged, very helpful, very supportive of what we're doing. And like through the process of talking to people, you realise how many assumptions that you make as a researcher and the designs of research that we do. Even when we're going in with good intentions, we realise that we're making a lot of assumptions that need challenging and need calling out, and people are willing to do that, and we're learning a lot from it.
You know, I think that's quite common. That we all do it in real life, but it is hard when it's somebody else's life that's sort of caught in that.
Yeah.
So it's nice that the patients are getting involved.
Yeah, no, it's been a great project, and we've had a lot of support from a number of different organisations, but Scleroderma BC have been a big supporter of our work. So yeah. Good.
And health policy, where do you see health policy going? Are you seeing some new trends?
Well, I think there's like with the move towards multidisciplinary care, which I think is rheumatology has been a big leader of that in BC. That's kind of an exciting direction, I think, because the more we can get away from working in silos and working with individual specialists to thinking about holistically what the patient needs. And this again is stuff that came through when we were talking to the scleroderma patients, multidisciplinary teams, thinking even beyond the medical model, so people to support, of course, the medical needs, but beyond that, the sort of broader issues that people are dealing with disease. I think any direction we can go in that way is going to be helpful, and I hope that's the direction we're going.
I like to think it is. I was diagnosed 24 years ago, and I remember thinking that I was in a tube, and everyone was making decisions on me.
Yeah.
And I don't think that's quite the same anymore.
Okay, you feel like it's...
I think so. Or maybe it's just that I've been through it enough that, that it is. But no, I see a lot more patient engagement. 24 years ago, I don't think that you would have been asking scleroderma patients what they thought or how they felt.
Yeah.
So I like to think that it's moving in that direction a little bit, anyways.
Yeah, and I think it's a nice way of doing health economics and health policy, because I think our sort of field of research generally has a negative perception of that we're people that just care about the costs or care about value for money, which is kind of a positive approach. But I think the work we're doing is actually using health economics methods where we try and reveal people's preferences or understand people's preferences, and that's really powerful in shaping how we deliver healthcare. So I think it's great work, and I think it helps, I hope, to sort of reveal the more friendly side of health economics.
We like it. And anytime you combine health economics and policy with pharmaceutical, I'm on your side, so that's good. Good. And if you were to give any advice to a student going into the department of, into the field of pharmaceutical science, is there a specific thing that you would tell them?
I don't know, actually. So I'm a slight anomaly in pharmaceutical science.
I know you are.
Yeah. So I'm not a pharmacist. I don't have any I'm not any training as a pharmacist.
Even though you're in the...
Yeah.
So what is your training on? Sorry.
I've been
I should have asked that right at the beginning.
I've been on a funny route. I started out in kind of business and economics as an undergraduate degree. Didn't ever feel like I really fitted into that, and I almost quit that course, but I ended up doing a project in the NHS where I went in the medical negligence department. And just in that year spent with the NHS, I got fascinated by all the things that were kind of going wrong in the healthcare system and seeing how we sort of picking up these consequences of bad care. And that sort of changed my direction, and from there I did epidemiology as a master's degree after that, just to give me the tools to research these questions that were coming up. And my first job was in an arthritis epidemiology unit, but quite quickly after that, with the event of biologics and that era coming in, the health economics thing came back in, and I kind of got sucked into the area that I escaped from. And I've been working in there ever since. So yeah,
it's always a pleasure to talk to you and listen to you talk. Yeah.
My pleasure.
And Anita, have we got any questions?
What defines multidisciplinary models of care?
Okay, so that's generally I think of it as being more than one person. I'd like to think of it as much broader. The model we're looking at in BC is just a rheumatologist and a nurse, but I'd like to see much broader than that. So that's a very narrow definition, but it could be involving as many different people with different aspects of patient care as possible.
So rather like the clinics that they've now got for other things, where they've got a physiotherapist and an occupational therapist and a social worker and a whatever.
Exciting stuff, yeah. The bigger the better.
We'd love that too. Anita?
What advice do you have for students who are interested in health policy?
Be tenacious. It can be a long road. It can be a challenging road, but I think it's ultimately a rewarding road. And I think if I could say anything from my experience of recent years, is go out and talk to people. Talk to people who are affected by what you're studying and know more about you than what you're studying. Talk to the patients to get their perspective, and you'll sort of reveal a lot of your biases, and you'll learn a lot about how to do a better job of studying those areas.
Perfect. Thank you so much for coming again, Dr. Mark Harrison. I know that we've talked before, and we hope to have you back again. In the meantime, just soak up all that CRA information.
Will do, yeah.
Thank you.
Thank you very much.
Oh, hold on. Sorry. We have one more question. Why?
Oops.
We will table that question, then follow up with Mark Harrison in an email.
Sure.
Thank you.